Okay, so if we go through the cervical region to start with, just familiarization. So if we come off the occiput, what you end up with is a fair old dip where that C1 and potentially C2 are, and then we just count down C3, C4, C5, C6. You'll usually find that C6 will disappear once they start to extend that cervical region. So if you want to differentiate between C5, C7, usually that C6 will disappear. So that'll make sure that you know where that is. So the spinous processes are all sort of angling up towards the eyes. So it's really important from the facet perspective that if you are palpating, that you take that into consideration. So don't apply the force horizontally, try to apply it at a slight angle up towards the eyes. You'll see that that angle increases as you go through the thoracic spine. And obviously kind of the major difference being that your thoracic spine has the rib attachments on there. So we've got all your costed transverse joints that sit through that thoracic region. Your facet joints just sit in this small little gap in between each of these pillars, and then we have that transverse process. So you often find from that spinous process, a bit of a dip, fall onto the transverse process, and if you want to palpate it, we know that the transverse processes are directly across from that spinous process, whereas in the thoracic region, if we go straight across, we sit in between. So we know that it always sits that little bit higher. Other things that are worth noting is obviously all of the nerve roots that come out from the little small holes off that spinal cord into your dermatonal, myotonal patterns. So that's really important just to note and learn that side of things. Now, as we kind of transverse across, obviously we've got our ribs. So there is potential for irritation that happens at this costo-transverse joint potentially within people if they've had impact into ribs, potentially kind of had coughing situations that are quite violent, etc. And then we move into the scapular region. So key sort of structures is the spine of the scapula that winds around and becomes your acromion. So we've got the posterior acromion that we've had some fractures in. We've also got the anterior acromion and the arch that it creates underneath and forms the roof of that shoulder joint. Because it's above, we've got your supraspinatus that just sits in this supraspinous fossa, attaches across here. So involved with the initial sort of 10-ish degrees of abduction, also centering that humeral head inside that glenohumeral joint. So potentially when we think about anything that is happening impingement-wise in here, the fact that your supraspinatus works really hard to keep that centered, and rather than it rising up and keeping it kind of medially positioned, really important to try and prevent some of those reoccurring impingement signs, either of the tendon or that subacromial bursa. Below the spine of the scapula, what we have is the infraspinatus and also the teres minor that comes in to attach laterally. And what that does is that lateral rotation. So as the pull occurs from here, what you end up with is a lateral rotation of that humerus. Now, as we wind around to the front of the shoulder, you'll clearly see sort of head of humerus. We've got the acromion and then obviously that clavicle or collarbone that comes across here. So that forms the AC joint. So if you've had a direct fall or an impact into this region, what you sometimes find is that there's a disruption of the ligaments that either sit between the bottom of that clavicle and the coracoid process on there, or potentially between the acromion and that coracoid process there. So let me just turn these lights on. There's not a great deal of movement in that AC joint at all. There shouldn't be. It's a lot of ligamentous tissue holding that in place. You sometimes get a little arguable bit of rotation, but you often find it doesn't like that cross-body adduction and it doesn't like that terminal abduction position. Now, as we walk across the collarbone, you can clearly get fractures that can occur within here. Usually when they've happened, they've been sort of central or slightly lateral clavicle, when we've seen them in rugby and judo. And then if we walk all the way to the medial aspect of that collarbone, then what we have is that sternoclavicular joint. So we've got the manubrium of the sternum, we've got the body of the sternum, and then the Ziphy process that sits at the bottom. Now, again, what you can end up with is a disruption in that joint. That sternoclavicular joint tends to take quite a long time for it to calm down. It might sit a little bit proud when you start to palpate it and compare it to the other side. Now, as we walk down the sternum, you'll see that we have some costal cartilage that sits out here, and then that joins the rib. Why is that important? Well, if you get an impact or a blow into this region,